My name is Simon Pimstone. I'm a founder and CEO of Zion Health. We're a company dedicated to providing innovative solutions to men and women with hair loss. I'm absolutely thrilled to be able to kick off our podcast series with Dr. Robin Unger. Robin is a very well-regarded hair restoration surgeon based in New York City, and one of Dr. Unger's differentiations is a large percentage of her practice is dedicated to women with hair loss, providing both medical and surgical options. Dr. Unger's achievements are many-fold, and I won't go through all of them today, but suffice it to say she's really one of the best known in her field, and we're very privileged to have you with us today, Dr. Unger. So thank you for joining.
Thank you. I'm blushing.
Please don't. Well deserved. So, Dr. Unger, maybe we can start at the top, which is why do women lose their hair? And perhaps you can discuss for our audience what you see in your practice as the most common causes of hair loss in women, looking at it from an age perspective, those women that are perinatal, postnatal, premenopausal, and then those women that are menopausal or postmenopausal, because I think while there might be some degree of overlap, there are lots of differences, and would love to get your thoughts on that.
Definitely. There are differences in the population and what causes the hair loss in different age groups. So in the premenopausal group, I would say my first suspicion is hormone imbalance. My second suspicion is hormone imbalance. My third suspicion is nutritional deficiency. Very often there's some coexisting diet restriction or eating disorder or an absorption problem. We have a lot of patients that have unhealthy guts or, inflammatory bowel diseases that have not yet even been diagnosed. And so in the younger patients, I generally do a fairly thorough workup or refer to an endocrinologist for a thorough workup. And the main hormonal issues we're looking at in, just after puberty and in the early 20s is looking for androgen excess, or even if it's not frank excess, it may just be an androgen hypersensitivity. So their numbers may be okay. I'm not a big, let's just look at the labs. Let's look at the symptoms. Do they also have hirsutism? Are they also having trouble maintaining their weight, some sort of insulin resistance? Are they also having hair loss? If you look at the picture and it's suspicious for androgen excess, and there's not a frank androgen excess, but there is obvious androgen effects, I treat it as though it's androgen excess. So that's the younger age group. Once we get in the 30s and 40s, we will say, in most cases, there is some genetic predisposition in many situations. There's also a lot of hormonal issues. We have a high incidence, at least in New York, of thyroid issues. I think they often get missed for a very long period. We also have a lot of patients that have some of the dietary restrictions that they choose may lead to a protein insufficiency or some nutritional deficiency. Any systemic illness can cause a chronic telogen effluvium, extreme stress. Definitely have a lot of that in New York. And certain medications we would look at, because antidepressants, certain birth control methods or specific pills, epilepsy medication, even the statins, some of the statins we'll see associated with hair loss. So that's our middle group. And then we have perimenopausal and menopausal, and those are the very high percentage of women will go through significant hair loss in that period of time. And it's not a mystery. We know estrogen and progesterone decrease, the androgen effect increases, we get hair loss.
Yeah. Well, I want to come to the pattern hair loss in that age group in a moment, but some of the things you said very interesting in the premenopausal setting. Endocrine sensitivity obviously being a very interesting one. I think often people don't realize even in men with hair loss, it's not because their testosterone levels are necessarily high. It's because of the sensitivity of the androgen receptors to DHT circulating that could be quite normal. So I think this is a very important concept for the audience to appreciate. And how much of that, Dr. Unger, would you say is genetically determined?
Probably
when you look at these individuals,
huge percentage.
Yeah. So family history, really at any age when you see hair loss, is an important risk factor in your mind, is it?
It definitely is, although we know it has increased in the population over time. Any disease continues through the generations, tend to get a little more severe. We've definitely seen that with hair loss, and whether that's because there's an increase in thyroid disorder, autoimmune disorders, or allergies, all of those things that may play a part.
I think, the other thing we talk a lot about is with weight gain, and as over time, as a society, we've gained weight, it creates this inflammatory state, which I think the pilosebaceous unit, the hair follicle, is no different from other endocrine units in that sense, and maybe actually very predisposed to pro-inflammatory circulating cytokines and other factors. I think one of the things you mentioned about medications and hair loss, of course, being interesting. I think even drugs like Ozempic today, I think there's some thought about possible hair loss with that. Do you care to comment on that, Dr. Unger?
I've already seen quite a lot.
Interesting.
I've already seen quite a lot. We don't know definitively what it's related to, whether it's for absorption or rapid weight loss or the medication itself. But I definitely have seen it. And a large number of my patients are taking Ozempic.
And what about COVID? Because we see a lot of patients, certainly I do in my clinical practice, or we hear a lot on our website from customers and patients about, could their hair loss be related to COVID or long COVID? Have you seen in your practice COVID as a potential underlying cause of hair loss in both your male and female patients?
Yes, in both. We see COVID-associated hair loss, Epstein-Barr, Lyme. We see it with a lot of the kind of diseases that can become chronic and that can have a very acute phase. So that's the extreme stress on your body. Basically, anything that causes extreme stress on your body.
Is that typically a telogen effluvium-like pattern, or can they develop really pattern hair loss as well as related to those stresses?
Well, so that's something that comes up frequently in my practice. And someone will say, oh, but the other doctor told me it's a telogen effluvium, and you're telling me you're going to treat me for the androgenetic alopecia, but I thought it's a telogen effluvium. Sometimes the telogen effluvium unmasks an underlying androgenetic pattern that wasn't really evident until they lost more hair generally. Then you see a patterned hair loss underneath. So while treatments for telogen effluvium are difficult, it's usually tincture of time, maybe minoxidil to bring it back a little more rapidly, but we can address the androgenetic component that's underneath it. And that's another thing that I think is really important for listeners to understand is hair loss might just be written off as, oh, it's with age, or it's a female pattern, or it's this. If your doctor is not taking out one of these, if they don't have a dermoscopy, you should find one who does. Because the analogy I use, if you see a herd of wild horses, they might all be horses, but there might also be a mule hidden in amongst those horses, and you need to be able to know when to find it. So is it androgenetic? Is it telogen effluvium? We can go by history, but we also can clearly see the miniaturizing hairs on dermoscopy. Those aren't seen with telogen effluvium. Is it LPP or FFA, one of the autoimmune diseases that is really a trichologic emergency? We need to start treatment. We need to look and evaluate the patient after we get their whole history and medical background, everything like that.
Maybe just for the audience, Dr. Unger, if you don't mind describing what is telogen effluvium. I know I threw that in as a potential entity, but perhaps what is it and in what circumstances do you see it? You've touched on treatment, but I do know this is a big issue for many men and women, particularly women, and it can be devastating to have these just sort of sudden loss of hair in patches or in certain areas. Perhaps you can just touch on that.
So telogen effluvium is a rapid shedding of the telogen hairs, which are the hairs that are not in the growing phase. And it usually happens in response to extreme physical or emotional stress. It can happen in response, after a major surgery. Sometimes we have patients, we can't figure out why they have the telogen effluvium. We see there is some sort of systemic illness or systemic medication that is causing this telogen effluvium. And sometimes we can identify it, sometimes we can't.
Yeah.
Yeah.
Let's talk about, before we get into sort of menopausal and postmenopausal pattern hair loss, perhaps hair loss associated with pregnancy or partum with delivery. We get a lot of questions about that from listeners and from customers and patients. Can you perhaps talk a little bit about what you see in terms of younger women who are pregnant, and what we can advise women perhaps who may be getting pregnant or planning to get pregnant as to what may happen to their hair? What should they do about it? How much of a cause of panic is it if they see some hair loss?
So first thing I tell them is it will happen to everyone. Like, just expect it and don't panic. Because the first instinct is to panic and do like 600 things to try and save it. Expect it. It will happen because there's a rapid decrease in estrogen. There's a rise in prolactin, which causes hair loss. We know, like in patients with prolactinomas, we know they get hair loss. So those two combined factors are going to cause a shedding. The shedding is temporary. It is not permanent. And partly, it's also because the shedding was suspended throughout pregnancy.
Right.
It's basically suspended. So you got extra good hair for 8-9 months. It's going to get worse after the baby's born, but it will come back. It will come back. That's not the time to go start seeking procedures. You don't need to. That's a time to make sure nutritionally you're taking care of yourself as best as you can. With a new baby, you're trying to get some sleep as much as you can, and just give yourself a little bit of time and space. It does come back. If you want to try and bring it back faster, you can use minoxidil, because that speeds the hair into the anagen phase and prolongs the anagen phase. But even that, I worry a little bit for patients to start it then, because then they're afraid to stop it ever. Right. So if you've just had your hair loss due to pregnancy, you're going to have to stop it if you're going to have another baby. Usually the OBGYNs want you not to be using minoxidil during pregnancy. So I don't want them going up and down on it.
And what about the use of minoxidil in women who are breastfeeding after they've delivered? Is that generally something that you consider safe, or do you reserve that for women who really, really need it?
Usually I will defer to the OB or the pediatrician on that, because it varies how they feel about it. Okay. And it's really their department.
Yeah, 100%. Yeah. I totally understand. Let's move towards menopausal, postmenopausal hair loss, pattern hair loss being probably the big category. How common is pattern hair loss in women as they reach menopause and age beyond that? 1 in 2, 1 in 3. What do you see?
In perimenopause, everyone will have decrease in density. I don't think there's a single person that will escape it. The difference is, how much did you start with? Is it really going to even show? If you're one of those women who started with like hair that the hairdresser had to thin your whole life, you might not even notice that it's thinning during perimenopause. But estrogen decreasing, progesterone decreasing, increase in the androgen effect, it's going to happen. Postmenopausally, I think the number that has been proposed is more than 90% of women will exhibit visible hair loss at some point. And again, it depends on when it started, how much hair you had to begin with, as to whether it really bothers you. I have women that will come in perimenopause to my office. I have women that will come in just after menopause. And some women don't show up in my office till 70, but they're still showing up.
Is there any way clinically to sort of predict which of these women will progress rapidly versus very, very slowly, and whom it may not really be that noticeable to them or others over time? And where I'm going with this question is, at what point does one think about treating? So perhaps, the first question is, can one predict how accelerated hair loss might be in an individual? And secondly, is it important, if we're going to think about treating, to treat as early as one can to optimize the effect? And by treating, I mean at this point medically. We'll get to surgical options in a moment.
Right. So this is what I explain to my patients. I really think it's important they understand this is a progressive condition. And there's no point at which it raises its hand and says, I'm done with you. So whenever you start treatment for it, you kind of need to know that you're at a place mentally that you can be committed to it, that you're not going to go on and off, because many of the medications, when you start them, cause an initial shedding. When you stop them, cause a shedding. So we don't really want somebody who's not yet ready to commit. So if you start too early, they don't see any difference. They don't know the value of it. It's hard to stay committed. I usually like to see that they're at a stage that they will note the improvement, that I can put up a photo and say, okay, this was you before you started minoxidil or finasteride or dutasteride. This is you before, this is you now. You can see the difference. So now you feel committed to staying on it. And I would say as early as we can get that kind of noticeable difference is the best time to start, because much easier to hold on to a hair than to try and bring it back.
Yeah, I think this goes for many disorders in medicine is,
Yes.
earlier treatment is just a much easier way to optimize the outcomes than trying to chase it too late. We see this
Right.
across many different disorders. So I think that's a very important point for women, listening to perhaps appreciate to, if you feel you need it, has been a noticeable acceleration in hair loss, go seek expert opinion as to whether you may benefit. And then, as you say, Dr. Unger, be ready to commit, because this is a long-term commitment. And it's one of the questions we get a lot is, well, once my hair is thickened, or if I've halted the progressive loss, can I go off the treatment? And I think the answer is you can, but you will result in shedding and thinning, and you'll land up probably where you were.
So the example I always give my patients is, if you were a diabetic and you need insulin, it will control your blood glucose. But if you go off the insulin, your blood glucose will go back up. It's a chronic disease which we have a treatment for, just like androgenetic alopecia. It's a chronic disease. We have a treatment for it. But if you go off the treatment, well, the treatment stops working. We don't have a cure at this point. The other thing maybe is important to emphasize is a lot of patients I'll see shopping around, going doctor to doctor, thinking somebody has the magic answer, the magic pill, the magic treatment. There is none. If there was, I would know about it. There's no magic. We all know what we know. There's hair research going on. People lecture about it. People publish it. Anything that's not being lectured on or published just doesn't have medical validity yet.
And I like to say, if something sounds too good to be true, it's probably not true. So I think that's the other important message we often give is commitment. It's long term. There's no quick fix or no magic bullet. This is probably multifactorial in how you approach it. In terms of treatments, can you give us sort of your approach to treating a woman with, let's call it pattern hair loss in their 40s or 50s? Are they peri or postmenopausal?
I like my patients to know what their options are, because it's not one size fits all. What's best for me isn't necessarily best for the patient. But if you look at the medical literature, number one on the list for women is minoxidil, either oral or topical. So that's usually my first line treatment. After 9 months, we evaluate. If it works, we continue. If it doesn't work, we stop it. If it works but not well enough, we layer on option number 2. One of the regenerative treatments, I offer the PRP as well as the Alma-TED as well as the Fotona. And they all work on a similar theory, which is we're going to disturb the surface of the skin. We're going to add growth factors, biomimetic peptides, and we're going to see if we can regenerate follicles and create a better soil or scalp atmosphere for them to be growing in. Finasteride and dutasteride are on my list for women, mostly in the postmenopausal group. And There's the topical and there's the oral. They've both been tolerated well. So I would say that's probably the order.
And what about for women who are interested in hormone replacement therapy or bioidentical hormones? We have a lot of women coming in questioning about that, or they're on it already. We know there's a lot of controversy and pros and cons in terms of breast cancer risk or endometrial cancer risk or cardiovascular protection. Let's put that aside for the meantime. But in terms of utility of HRT or bioidentical hormones for preservation of hair in menopausal, postmenopausal women, any thoughts or comments on that?
Personally, the one that's going to put up my hand, say I'm a huge fan of hormone replacement therapy. Unless there's a set contraindication, I think there are many benefits to it. Cognitive function, as well as hair, skin, nails. Yes.
So I think, again, important to, as part of your regimen, to speak to hair experts, but endocrinologists may also be a very important part of your process for a woman going through solutions. What about the drug spironolactone, which we know is used in those androgen-sensitive patients, particularly polycystic ovarian syndrome, for example, younger patients with insulin resistance, etc. Your use of spironolactone in menopausal or postmenopausal women, can you perhaps discuss that with the audience a bit?
So I probably differ from most of the colleagues in my field. I'm not a big fan of spironolactone. I was raised in Canada. We had cyproterone acetate, which is a true anti-androgen, far better. In the postmenopausal group, we know that dryness, dry eye, dry tissues elsewhere is already an issue. We know bladder control's already an issue. Now we're going to give them spironolactone, which has a very low anti-androgen activity. It's just a side effect of the actual medication. I'm just not a huge fan. I don't know why we would choose that over finasteride or dutasteride or cyproterone acetate, which are true anti-androgens.
And before we get on to, I want to just touch on low-level laser therapy as well as diets, etc. But how common, because you gave us a very nice kind of sequence of interventions, kind of one step at a time. Is there an argument to be made that polypharmacy, when we talk about multiple mechanisms, perhaps, I like to think of, and maybe I'm incorrect in this, but I've always sort of thought women's hair loss perhaps has a more complex etiology than male pattern hair loss, where one can look at androgens and androgen sensitivity as really the primary factor. I think with women, it does tend to be more complex, and part of that is evident by their response to medications being somewhat different and sometimes requiring more complex regimens. When do you decide to do that sequential one step at a time, as you've outlined, versus to say, look, your hair loss is rapid, it's aggressive, you're very worried about it, I'm going to put you on minoxidil, either oral or topical finasteride or oral or topical dutasteride as a complementary strategy. Is that something you introduce in the right patient?
Yeah. I don't have one size fits all approach to women or men. I look at the scenario. So the women who are really in a very rapid or acute period when they come to meet me, we'll start them on more than one modality because there's a higher chance of success. Thing I like to avoid is throwing 3, 4, 5 things at them at one time because they won't stay committed. They'll say to me, they got that from another doctor. They got put on minoxidil, they got put on finasteride, they got started on low-level light therapy, they did PRP. I mean, they did this huge host of things, and then the patient comes to me, I'm not really sure if it worked or what worked. So it's very hard to stay committed in that scenario. On the other hand, if a woman's coming to me and she's already in fairly difficult situation, her hair loss is already quite advanced, we're not worrying about the theory at that point. We're worrying about trying to bring their hair into a stable period, reverse some miniaturization as quickly as we can. So, yeah.
You mentioned some other modalities like PRP and let's call it exosome-like growth factor delivery, microdermal abrasions with microneedling, I guess, and those types of maneuvers. How important is it when you use those measures on a patient to complement them with medications, or are they usually sufficient on their own? Because often people will go for PRP, they will leave not on a medicine to assist long-term the maintenance of and optimization of scalp health and hair growth. Is that your practice, to just do it on its own in isolation, or do you usually complement those maneuvers with medications as well?
So as I said, usually I start with medical therapy. So many times the reason somebody's gone to PRP is they failed medical therapy or they couldn't continue it for some reason. They had some adverse event. If they're on medical therapy and it's insufficient, then I layer on one of the other modalities. If they are a patient, and I do have a large group of them in the city, as well as they come from surrounding areas, who are just really medication adverse. They currently take no medications for any conditions. They're not good at sticking with a regimen of putting something on their head every day topically. And so they've opted for the PRP because my PRP is done basically once a year. So they get to kind of forget about their hair loss in between. And I've been doing it 15 years and it's held true. Okay. Of course, if they're on something like finasteride or minoxidil in addition, it will probably hold even longer. But it's usually for the patient that's resistant or has failed medical therapy.
Surgery for women. Many of the listeners may not be aware it's offered, and some will have questions as to, can women get as good a result as a man with a surgical approach? Perhaps you can just comment on when you consider surgery in women and how women tend to do with surgical options.
So great question. And I would have had a very different answer over 20 years ago when I started in practice, because when I started, I was one of the few women surgeons and one of the few people very comfortable and happy to treat women surgically. So I probably had 60% of my practice was male and 40% was female in the surgical suite. I would say today, women are probably below 20% in my surgical suite. And the reason for it is not because they didn't do well with surgery. It's because they do so well with other modalities that we don't necessarily ever have to go to surgery. If a woman is already in a place where she's lost a lot of hair and we really have an aesthetically important area they can't camouflage, surgery is a great option. It works just as well for women as it does for men, as long as you know to prioritize the area that's aesthetically the most important. Right. You're not trying to treat every area that's thinning on their head, or you'll make absolutely no impact anywhere. I always use the description. If you put a pack of wildflower seed that's meant for a 1 acre plot outside your window in the little garden piece there, you're going to have a beautiful carpet of wildflower. If you spread it over 200 acres, you're going to have a bunch of weeds. So I always tell the women, if you say to me, your area of concern is this, then I'll say, okay, surgery is not a great option. If they can really pinpoint, if I could just get this spot thickened or these spot thickens or down my part, that we can do. In the patient who has a donor area that has been preserved over time.
General lifestyle choices, exercise, diet, shampooing, how often? Yeah. What other advice do you give to your female patients in how best to preserve their scalp health and the integrity of their hair?
So many of my suggestions women won't like. But one of the answers is most of the damage that's done to our hair, we do. So women are processing their hair, over drying it, using products that actually are damaging. And some of my patients will say, do you think it's really bad that I color my hair because they can see I don't? And I say, this is my answer on treatments. If it stings, burns, or hurts your scalp when it's being applied, get it off and don't repeat it. It's causing damage. If it doesn't, it's probably not causing damage to the follicle, but it certainly is making your hair itself look maybe drier, more brittle, breaks more easily. Tom Dawson gave a great talk on this about how we protect our hair. So using actually the leave-in conditioners or oils are even better than the rinse-out ones. Scalp treatments that stay on the scalp are also superior in the States and Canada as well. Yeah, we tend to have everything wash in, wash out, right? You know, you put it on and then you wash it out. It doesn't do a whole lot.
Diet, exercise, any recommendations on diet, supplements? There's lots of buzz on biotin and vitamin D, for example.
Yeah. So what I say, get your vitamin levels checked. Are you normal vitamin D, vitamin B6, vitamin B12? Are you normal? Iron, check. If you're normal, you're fine. If you're not, then yes, you do need to supplement, and you can supplement with what you're missing. Make sure your gut health is good. There's a gut microbiome. There's a scalp microbiome. So the omega-3s, part of the reason everyone's recommending those is because they help, you know, when women are older and they have drier scalp, it helps it be less dry. It's good for your gut. Make sure you have sufficient protein. That's a big one. So I usually will say, look at fish, nuts, things like flaxseed, all of those.
Polyunsaturated fats.
Yeah. All of those are very good. I do recommend people look at their diets and evaluate them. So sometimes you need a workup before you can decide what you need to supplement. I like the scalp massage, and you don't need to get some expensive one. What do I have here? I have one like this. Yeah. See?
Yeah.
I think it's actually very helpful to get product on your scalp. Oftentimes people ask about washing their hair. And I say, actually, you're not really washing your hair. You're washing your scalp. And I will show them. I will say, it's not this. You're not doing this. You're doing this. You're getting under your hair, washing your scalp. So especially for men, giving them something like this to rub it in is often very, very helpful. And I actually display it for them. How do you wash your hair? And finding the right shampoo for the patient. Yeah. It's not one size fits all. There's patients with super oily scalps, dry scalps, seborrhea. There's a right shampoo. And if someone comes to me and they say, I washed my hair this morning, it's already oily, it's not the right shampoo.
So we get a lot of questions.
Yeah.
Can too much exercise result in hair loss? A lot of men are worried because of testosterone replacement or related creatine, as bodybuilders often use. But women as well, intense exercise is a factor. Do you see hair loss in people that exercise intensely, or is that not something people should be too concerned about?
I think it's hard to tease it out between those who are like hyper focused on exercise. They tend to also be hyper focused on their diet in a very restrictive way sometimes. They tend to take supplements that may be anabolic in nature. Exercise itself, if you're not pushing your body beyond its limit, I think exercise, a healthy amount of exercise is fine and good.
Yeah, this has been amazing. I've got so many more questions. Ponytails, ball caps. We can go on all day. We'll have to do this another time. You've been incredibly gracious with your time, Dr. Unger. So first and foremost, I wanted to thank you for what's been an incredibly informative session. We will ask listeners, if they're interested, please subscribe to the YouTube channel. Will be made available on our YouTube channel, Dr. Unger's website as well, and we'll be happy certainly to provide relevant references as well to some of the points that were made for our listeners to be able to read through. Dr. Unger, thank you again for your time, and look forward to catching up in the near term.
My pleasure. Thank you, Simon.